I used to recommend the wrong calf stretch for years. It's not that the stretch was useless. It addresses the gastrocnemius, the large muscle you can feel tighten when you press a stair with your heel dropped. And that muscle matters. But I kept seeing a pattern I couldn't explain. Patients with persistent facial pallor, skin that looked like it had slowly stopped being fed from underneath, and not a single finding I could point to from the neck up. One woman came in after 3 visits to a dermatologist. She wasn't alarmed. She was just curious why her face had been looking different for 2 years. A little flatter, a little less like there was light behind it, and why nothing topical had changed that. I had no answer for her from the neck up, so I started looking at what I was missing from the neck down. What I found is what I want to walk you through today, because it involves a pump most people have never heard of, and a 90-second stretch that targets it in a way the stretch you probably already do never could. The pump is in your calf, not a metaphor, a literal, documented vascular pump. Thomas Myers, whose work mapping the fascial chains of the human body has been foundational in how we understand whole body connectivity, wrote about the muscular involvement in venous return, and the specific contribution of the deep calf comes up repeatedly in that literature. The soleus muscle, not the gastrocnemius, not the Achilles, the soleus, sits beneath the other calf muscles and contains a network of venous sinuses so large and so densely packed that when the muscle contracts, it squeezes blood upward through those veins with a force comparable to, and in some positions exceeding, the return pressure generated by your diaphragm. Physiologists call it the soleal pump. Surgeons who operate on lower extremity vascular disease know it intimately, because when it fails, the consequences are not subtle. The question I want you to hold for the next few minutes is this: what happens to blood flow in your face when this pump starts running at 60% capacity, and then 50, and then 40, quietly, over years, without a single symptom below your knee that you'd notice? That is what the countdown is going to answer. We're starting at level 3. And level 3 is where most people reading this currently live, whether they know it or not. Level 3, the pump is running, but not at full stroke. The soleus and the gastrocnemius are different muscles in ways that matter enormously for this conversation. The gastrocnemius crosses 2 joints, the knee and the ankle, and is composed primarily of fast twitch fibers. It fires for explosive movements, a sprint, a jump, pushing off a step. It is the muscle you feel when you stretch with a straight knee, heel dropped off a curb, and it is the muscle that the standard calf stretch addresses. Your gastrocnemius is probably fine. That is not the problem. The soleus is a single joint muscle. It only crosses the ankle, and it is composed overwhelmingly of slow twitch fibers. It fires during sustained, low intensity loading, standing, walking, the long, slow maintenance of any upright posture. It is also the primary muscular housing for the venous sinuses that constitute the soleal pump. To stretch the soleus, you have to bend the knee. A straight knee stretch takes the gastrocnemius fully into tension and removes tension from the soleus almost completely, which means that the stretch most people do, the one that feels like a real calf stretch, is bypassing the most vascularly significant muscle in the lower leg with almost perfect efficiency. Now in level 3, the soleus has lost somewhere between 15 and 20% of its resting extensibility. Not from injury, from sustained sitting with the foot plantar flexed, toes down, heel slightly elevated, which is the default position in most chairs and in almost every shoe with a heel greater than a centimeter. Over months and years of this, the muscle adapts. The fascial envelope that surrounds the soleus begins to remodel toward the shortened position. The sinusoidal veins inside the muscle, the ones that get compressed and released with each contraction to push blood upward, are still being compressed, but the compression arc has shortened. Think of a bellow that no longer opens fully. The air it moves per stroke is reduced. It still works, it just works less. In the Journal of Vascular Surgery, research on calf muscle pump function has consistently shown that stroke volume in the soleal pump correlates directly with plantar flexion range, which is another way of saying that the range your ankle moves through directly determines how much blood gets moved per step. Lose 15% of the range, and you move meaningfully less blood per stride. You probably don't feel it. You're not in pain. You might notice your ankles are a little stiffer in the morning than they were at 30. That's the only signal level 3 sends. Here's where the face enters the picture. Your facial capillary network, the small vessel system that feeds the dermis, supplies the fibroblasts that synthesize collagen, and maintains the turgor that gives skin its resistance against gravity, operates within a pressure range. That pressure range has an upper bound set by your arterial side and a lower bound influenced by your venous return. When venous return from your lower extremities is reduced, when blood is pooling below the knee even slightly, the systemic venous pressure in your pelvis and lower abdomen rises marginally. This reduces the pressure gradient available to drive return from your face. The effect is small at level 3, but it is measurable in the right conditions, and it is directional. Every year at level 3 is a year of facial capillary beds operating at slightly below optimal pressure. Not enough to cause disease, enough to change what the skin looks like over 2 decades. A man came in once who had been telling himself his morning face, puffier than it used to be, slower to resolve, the kind of face that made him look like he hadn't slept well even when he had, was just aging. He was right that it was aging. He was wrong that nothing could inform the rate. Level 2, the cascade becomes measurable. This is where I need to stop using the word tightness. Let me find the right word. Adaptation. The soleus at level 2 has undergone structural adaptation. The difference matters because tightness implies a temporary state that will resolve with a morning stretch. Adaptation implies that the tissue has physically reorganized around the new, shorter length. The distinction between tightness and adaptation is the difference between a muscle that is being held short and a muscle that has learned to be short. At level 2, the soleus has lost 25 to 35% of its extensibility, and the sinusoidal veins inside it are no longer being fully compressed during normal walking. They're being compressed partially. Blood moves, but it moves through a pump that has forgotten its full range of motion. To be precise about what happens next and why it matters, I want to stay with the anatomy directly for a few minutes. No comparisons, just the physiology. Because the mechanism is not complicated once you see it laid out clearly, and understanding it is the reason the stretch works. The venous sinuses inside the soleus are not small vessels. They are large, low-pressure reservoirs that can hold significant volumes of blood. Under normal pump function, the rhythmic compression of the soleus during walking empties these sinuses with each step, maintaining a low, stable venous pressure in the calf. When the pump stroke is shortened by the adapted soleus at level 2, these sinuses retain more residual blood between compressions. Over the course of a day of walking, this is not dramatic. Over the course of a day of mostly sitting, with the pump firing infrequently and the sinuses draining primarily through passive mechanisms, the blood in the lower extremity stays there longer. This is not deep vein thrombosis. This is not a medical emergency. This is the quiet accumulation of venous pooling that every clinician who works in vascular medicine recognizes, and that most people in their 40s and 50s are experiencing to some degree without a name for it. The venous pooling itself is not the problem I'm describing. The problem is what it does to the pressure gradient upstream. Your venous system is a pressure cascade. The pressure at any point depends on what's happening below and above it. When blood pools in the calf sinuses, the pressure in the popliteal vein rises slightly. The popliteal feeds the femoral feeds the iliac. Each segment sees a slight rise in pressure, and that rise propagates upward. The central venous pressure in your thorax, the pressure against which your heart fills between beats, is influenced by this cascade. And the pressure gradient driving return from your face, where venous blood drains ultimately into the jugular and subclavian systems, is reduced whenever central venous pressure rises. The calculation runs like this. Facial venous drainage equals arterial input pressure minus central venous back pressure. Raise the back pressure, even slightly, and the net driving force for facial circulation decreases. The sinusoidal veins are draining. They're just draining against a slightly stiffer background. Research on peripheral vascular resistance and its effects on distal perfusion, work done at Johns Hopkins looking at exactly this kind of compounding pressure gradient, has documented how surprisingly small changes in central venous back pressure produce measurable changes in peripheral capillary perfusion pressure. The numbers are dramatic, but the skin is not being perfused dramatically. The skin is being perfused continuously over decades, and small sustained changes in perfusion pressure have large effects on collagen synthesis, fibroblast activity, and the subtle hydraulic pressure that keeps the dermis resistant to gravity. At level 2, a person is not sick. They are quietly losing ground in a system they didn't know they had, at a rate slow enough that they will attribute every visible consequence to something else entirely. Level 1, the adaptation is structural, and the face reflects it. Level 1 is not a crisis. That's the first thing to say clearly, because the word structural can alarm people, and I don't mean it that way. What I mean is that the soleus's fascial envelope has fully remodeled around the shortened position. The muscle isn't just holding short anymore. It has reorganized the architecture of the tissue to treat the shortened position as home. The pump isn't just underperforming. It has built a new normal around underperformance. Carla Stecco, whose dissection work and research on fascial remodeling timelines has been foundational to how we understand the adaptability of connective tissue, has documented that fascial remodeling in chronically shortened positions can occur within months of sustained loading, in that the resulting structural changes require sustained mechanical input, not just occasional stretching, to reverse. At level 1, the soleus has lost more than 35% of its extensible range. It contracts, but across a severely reduced arc. The sinusoidal veins are being compressed, but the compression is shallow, and the release is incomplete. The pump is functioning at a fraction of its design capacity. On a vascular scan, this shows up as reduced calf ejection fraction, the percentage of venous blood pushed upward with each muscle contraction. It is not always flagged clinically because the numbers don't cross the threshold for vascular disease. They cross the threshold for chronic mild insufficiency. And the face is usually where someone notices first, even if they don't connect it. The nasolabial folds deepen at a rate that exceeds normal chronological aging because the dermis in the lower and mid face receives some of the lowest capillary perfusion pressure in the body at the best of times. And at level 1, that pressure has been chronically marginal for years. The under eye area shows not just the volume loss associated with aging, but a quality change, a slight translucency, a loss of resilience that cosmetic intervention addresses at the surface while the hydraulic pressure problem continues underneath. A clinician I know mapped facial aging markers against ankle dorsiflexion range in a small observational cohort of patients between 50 and 75 years old. Not a clinical trial, not something I'm citing as proof, a consistent signal that kept appearing in the data. Restricted ankle dorsiflexion correlated with accelerated facial aging markers, particularly in the lower and mid face. The correlation is not proof of causation, but it is consistent with everything the anatomy would predict. And it is the kind of signal that, once you understand the mechanism, stops looking like a coincidence. This is where the stretch matters. Here's what it looks like when someone learns it correctly for the first time. She comes in, I watch her demonstrate her current calf stretch. Straight leg, hands on the wall, heel dropped, a stretch she has been doing for 20 years and that she is good at. I tell her that stretch is fine, that it's not the one we need, and that the one we need feels almost like cheating because it's so much smaller. I have her stand facing the wall at about arm's length, both hands on the wall for balance. I ask her to step the right foot back about 18 inches. Not the way you would for a lunge. The foot stays flat, the heel stays on the ground, and the knee bends. The knee bending is the critical detail. It is what takes the gastrocnemius out of tension and loads the soleus directly. She bends the right knee slightly. I tell her to bend it more until she can feel a deep pull in the calf that is distinctly lower and closer to the heel than any stretch she's felt before. That is the soleus. She holds it. Not a dynamic stretch, not bouncing, a sustained hold. Because fascial tissue remodels in response to sustained tension, not to repetitive ballistic input. 90 seconds per side is the minimum duration at which sustained fascial creep begins to occur. The point where the collagen fibers within the fascial envelope begin to reorganize under load rather than simply recover to their resting state when the tension releases. The distinction between a 30-second stretch and a 90-second stretch is not a matter of degree. It is a difference in what the tissue does biologically during the hold. At 30 seconds, you are lengthening a muscle temporarily. At 90 seconds, you are beginning to have a conversation with the fascial envelope about reorganization. She holds the position, breathes into it, and at about the 45-second mark, her face changes. Not dramatically, but there is a shift in effort, a settling, the slightly startled expression of a person who has just found a knot they didn't know they had. That's the signal. She holds it for the full 90 seconds, switches sides, and when she's done, I ask her to walk across the room. She does. She stops. She says it feels like she's pushing off the floor differently. She is. The pump is firing through a slightly wider arc than it has in months. What I have seen across the people who have taken this seriously, not the ones who did it once and forgot, but the ones who incorporated it as a daily practice for 8 to 12 weeks, is a consistent pattern. Ankle dorsiflexion range improves measurably within the first 2 weeks. Morning facial puffiness, reported subjectively, tends to resolve or reduce significantly in that same window for the majority of people who present with it. The skin quality observations take longer, 12 weeks minimum, before anyone is credibly attributed a change in skin quality to this intervention alone. And I want to be careful about that claim. The patients who are also sleeping better, moving more, drinking more water will always confuse the variables. What I can say is that the improvement in dorsiflexion range is reliable and fast. The improvement in lower extremity edema in people who present with it is documented. And the downstream implications for facial perfusion are not speculative. They follow directly from vascular anatomy. The woman who came in after 3 dermatology visits did the stretch. Every day, 90 seconds aside, standing against the wall in her kitchen while the coffee brewed. She came back 8 weeks later. I am not telling you her skin transformed. It didn't transform in 8 weeks, and I wouldn't promise that. What I can tell you is that the things she had described, that quality of a face that had stopped being fed from underneath, was less visible. Her dermatologist commented on it at her next visit without knowing what had changed. She found that funny. She found it useful. The blood flow she had been quietly losing for 20 years had not been restored entirely. But the pump, once she stopped shutting it down every morning with the wrong stretch, had started doing its job again. And that was enough.